Well, welcome everybody. I want to thank you for joining us today. Right now we have Daniel Peach with us. He's from Florida and he's going to share some of his work at his hospital regarding his sepsis blast tool. Daniel, welcome.
Thank you, and hello to everyone. Just to give you a quick introduction, my name is Daniel Peach. As you can hear, I'm not a local from Florida. So I practice sports medicine within the UK and have currently been working for Advent Health for the last 8 years now. And I'm the executive director of clinical innovation within the clinical department at corporate.
Thanks so much. So today we're going to talk about the blast tool that was implemented at Adventist Health. How did you know you wanted or needed something like that?
So we know generally that sepsis is almost the scourge of healthcare and is one of those that has confounded everyone for the longest of times, and has been one of those areas that everybody has tried to pick at the fabric and eventually to pull a thread to be able to get a grip on it. And when one looks at the data continually, it starts to become a point that you have to grasp the nettle. You have to start really working hard with it. And at that point, what we've done is been able to start to pull data to really look into the depths of where there may be gaps that we need to look at. And that helped guide us in where we should start, which is often the hardest part with sepsis, knowing you have the problem and really looking at where can we make that initial step. And the blast was one of those areas which, from a clinical point of view, resounded with the clinicians and didn't really put the face of all of the other aspects of sepsis that tends to raise its head generally about finance and length of stay and all of those other areas.
So tell me, can you describe the blast tool a little bit since we don't have the picture of it right here?
Sure. So, really, what we're looking at with Blast is about getting that package. Now, we all know we tend to be governed by CMS, and so by taking the elements of CMS, allowed us to look at what we need to achieve, but look purely from a clinical point of view. And so, with the Blast, we're looking at getting that bundle components put together. So looking at getting our bloods in to be able to get the right testing done on those, get our lactate in early, look at getting the antibiotics as quickly as we can into the patient, and whether a fluid saline or otherwise, making sure that we put those in, and more importantly, getting them done all in a timely phrase, getting them done quickly, and structuring it so that we can expedite that process for the patient.
Thank you. I appreciate that. And so what do you think your first step was? It sounds like looking at your data was your first step, but what was your first step in developing this tool or implementing the tool?
Well, there's a lot of discussions now about implementation science and about how we get people to do things and how we draw them in. And to be honest, this is sepsis is really about good old fashioned doctoring and nursing. I often say one of the worst days' work we ever did was the change that was put on the naming, the nomenclature of what we deal with. And although it's not clinically correct, the old looking at the old terminology that surrounded sepsis of blood poisoning really invoked the need, the want to get things done quickly. So once we had the data, we realized that there was a need to expedite the process for patients. What frequently happens is people will consider a STEMI, a heart attack, or a stroke as being the really important areas. And there are structures that are built around that to deal with it and to expedite that process. And all of the hospitals, we get pretty good at that. It took about 10 years for everyone to really cotton on that there is a process that needs to be invoked there. And we looked at sepsis the same way. We structured it that once we've got the data, we knew where our gaps were, and to start to chip away at these one element at a time. And the biggest part of that was to really start to get away from that air of complacency that surrounds sepsis and to expedite the process.
Got it. And who did you need help from when you were creating this sense of urgency in your organization?
Well, one always needs friends and family in there, and everyone in Advent Health we count as friends and family. And the big part is down to the clinicians themselves and the nursing staff. When you have the data, you can present that often to the non-clinical staff, to the administrators, and they can see the value of, look, this is a problem we've got to deal with. But unfortunately, it's not as clear cut as being able to test, put an EKG on someone and test and say, hey, we're having a heart attack. And so it's a little more nebulous to deal with. So you've really got to go down to the roots. You've got to start communicating and working with the physicians and the nursing staff and get consensus on them of how to approach it and to really start to deal with this problem, because it is one that has many facets, and there will always be the excuse to not do something. And the decision of we need to do it and do it now really starts to promote that care and the need. And so working directly with your nursing staff, who are often the first and biggest identifiers of sepsis, and then your clinical staff to really start to listen and to communicate as a team, starts to promote the care that's necessary at that time.
Now, did you find you needed frontline staff as champions to carry this message and continue it?
So we have a structure. There are, as I said, lots of different philosophies and techniques used in getting people to make that change and get the cultural change in place. And we have a very specific way that we work within Advent Health that we've sort of worked with over the past 9 years or so. And that structure involves getting a champion that's available to you, someone not necessarily a leader of the normal thought process of being paid extra compared to everybody else. This is someone who actually enjoys the work that they're doing, has a real passion, and has that air that peer to peer people respect and they'll work with them. And that's not just with the physicians, but that's on the nursing side as well. And so utilizing those as champions who people will listen to and will follow is one of the really important parts of starting to invoke the change that you're looking to get about.
Perfect. Yeah, we often talk about, selecting your messenger wisely. Your message is one thing, but selecting that messenger is almost equally as important, if not more important. So did you feel like you used an improvement strategy? Did you use PDSA? Did you do small tests of change, or did you just try something?
So the English phrase is "wing it," and that we didn't do. There is structure behind what we do, and we over the years, Dr. Carmen and I have sit down and structured a different approach to healthcare change in general. And what we've looked at is within industry, it's very easy to look at PDSA, to look at lean, to look at Six Sigma. And to be honest, within healthcare, if we could get one Sigma, we'd be doing pretty well. So what we looked at is the way that we approach medicine as a whole. And engineering, which is where the basis of a lot of these change processes, is very linear in its outlook. Unfortunately, healthcare isn't. We produce widgets the same as engineering, but our widgets talk back and they never do exactly what they're supposed to do, as it says in the book. And so the thought process is more synthetical. We're looking at lots of things at the same time rather than that linear approach. And so when we took the approach of putting this into place, we looked at all of the elements that happen at once, and primarily within the ED, and to start at the front door, and to start to address all of the barriers, the concerns, and get the team working as one cohesive force in lots of areas at once, rather than trying to chip and change one element that leads to the next. Because unfortunately, when you change the second, third, fourth element, the first one breaks again.
Mhm.
So it's that combination of approach all in one go rather than that normal linear approach.
Got it. Got it. Now, if you talked about using data, what specific data do you use as a measurement of success with this tool?
So data can come in all forms, and often data will be presented to clinicians, and the first thing they'll say is it's a lie. That's not right. Um,
Kubler-Ross.
one, yeah, once you've substantiated it, then you're on the right road. But so the first part is you've got to make sure that it's accurate. What we try to do is not inundate people with data. We look at a handful of metrics at the very most as you go through with any of the pathways we put into place. And we look at that being clinically guided rather than administratively or financially motivated. So often there's always the length of stay that's attached, or all of these other elements that to a clinician, it doesn't really strike as being the bedrock of what you're there for and what you're looking to treat and accomplish. And so we try to look at things that are going to motivate that movement, that change in the clinicians and in the nursing staff. So when we measure, we're looking at when and how did we get the antibiotics in? Did we need to use fluids? And once you've got the structure set up, is to also embrace those that don't meet those normal criteria. Rather than saying to people, you've done it wrong, what we do is say, okay, you've done it differently. Why? And then use that feedback to iterate the process so that you have that constant change that keeps people motivated, keeps them focused. And so they're aware that the changes are not put there for an administrative need because we need to withdraw another person from the process, but more because it's the best thing to do for the patient and will help that clinical process as you go through.
Mhm. I love that appreciative questioning versus the punitive. Thank you. So a couple more questions. If looking back as you are today, looking back on yourself in those early days of rolling this out, do you have any advice for yourself? Or is there something you wish you had done differently?
Yeah, the first thing is always ask for more money. But failing that, I think sepsis as a whole is one of those areas where there's a lot of research that says the same thing. So you can't really expand the knowledge you have. I think the big thing that I would recommend to people is make sure that you have leadership from that administrative role really on board. And I know we always say that it filters down from the top, but with sepsis in particular, it's going to be a hard that you tend to push two elephants at a time up the hill rather than one. And part of that is because it is difficult. And when you're not going to get that immediate change that is often demanded within change within healthcare. If you look at industry, it normally takes about 10 years to make change. We work about 2.5 years within Advent Health, which is pretty good with getting that cultural change in place and sustaining it. And that's the important part of this as a whole. We don't just want to do it, make change and move on. We've got to make the change. We've got to solidify that and continue that change evolving so that it keeps in pace with clinical developments. So there may be a new test that comes out, or meeting the requirements of leadership as a whole. So I think looking back, I would make sure that I would get as high in the tree from a leadership point of view to get that consensus and the want and need to say, you know what, we're going to stand behind you for as long as it takes to get this through and not be confined by very tight timelines in something that we've not solved in many, many years.
Right, right. That's a really good, really wise, I think, too, to not have a time limit on it because, I mean, you and I've been working on it since 2006, I think. So, I mean, it's a tough nut to crack.
And but it's there, and it's one of those that I always say sepsis is the one opportunity for nursing to save a life. In all other aspects, nursing has to hand things over. This is the opportunity for nursing to stand up and say, this patient is sick, this patient has sepsis, we need to do something now. And to really pull the fire alarm. If you smell smoke, pull the fire alarm. Sometimes someone's burning toast and it's not a problem. But then when the times there are flames, you've rescued a lot of people and you've helped them get out. Rather than turn away and say, you know what, I'll wait for somebody else to see the flames and let them deal with it. And so invoking the nursing team at the beginning as being a big part of this really helps support the need. And we're hugely lucky at Advent Health. We have great physicians, we have superb nursing staff that are here, and the leadership has been supportive as we've gone through. So it's helped to coalesce that team with special regards with sepsis.
That's awesome. Did you hit any unforeseen challenges, or did you have some unforeseen wins?
No, because we plan everything perfectly. But but generally, what tends to happen is we don't count the barriers as being problems. They're actually areas of iteration. They're areas where you can learn and you can feed back into the system. So, what will be the speed bumps in other areas? How we tend to consider those is good learning opportunities. Now, clinicians will always push back, and if a clinician doesn't, then there's something wrong, because that's in the nature of what we do, and it's generally about, hang on, I want to question it. Prove to me it works. What I will say is once your clinicians actually see the benefits to the patients, they actually see how things can be made easier and expedited for the patients. Trust me, it will become their idea. They would have thought about it 5 to 6 years ago, and you should have listened to them then. So you will capture that. Nursing staff often are the slower changes that go on. And one of the big things, especially now with our newer nurses that may not have as much experience, is they tend to work more against protocols. They're working for that structure that they have. And one of the big things that we've asked of our teams is, let's get back to that good old-fashioned nursing. Let's get back to being inquisitive, of caring for the patient and spending the time, because remember, there are more patients that die of sepsis than do of STEMI and of stroke, and we've sort of ignored it. These are the ones that we need to really take care of. And if these patients progress into septic shock, we're now with patients that unfortunately are going to be attending hospitals for the rest of their life. They're also going to have the trauma that they went through there. They're going to end up with PTSD. The families themselves are going to go through a lot of problems during that period. So the approach that we take by treating that patient early, by getting the teams motivated to strike early and to start dealing with the issue, really means that you're taking a holistic approach to sepsis. So rather than, again, taking that linear chip by chip, let's deal with it in one go. Let's resolve it, and let's all stand up and really start to lead forward.
Great, thank you. Anything else you want to share about your sepsis program or this journey that you've been on with Adventist Health?
It's one of those constantly evolving. I would say never be afraid when things look as if they're going the wrong way, because again, that's part of that evolutionary process and the culture changes that go in. I would always recommend to get the feedback. One of the big areas we had to work on, we have recently turned over to Epic in our EHR, and we had to rechange the change of the change with regard to sepsis, because it really didn't reflect the clinical flow. The BPA alerts were there, and everyone thought they had tinnitus at one point because the beeps were going off all over the place. So making those changes helped resolve those issues, and more importantly, have an action associated with everything. So with the EHR, rather than it coming up and saying, hey, this may be sepsis, it needs to come up and say, this may be sepsis, what are you going to do about it? Are you going to fire off the order sets that are there? And utilizing order sets, if you can bundle those together, really is one of the godsends for your clinical staff, but also for compliance from that other end of it. Because if people can hit that and move on, and then add extras to the care that they need for those patients, it allows them to spend more time with the patient themselves and not on that administrative process. So try and help and support the teams within the EHR as well, with as much work tailored for that patient type as you can.
Great. Thank you so much, Daniel. Really appreciate all your wisdom and your pearls and your willingness to share your work with the rest of the hospitals in this country.